ودلوقتي يشرفني طبعا ان انا اقدم دكتوره مروه احمد مدرس امراض البطنه بكليه طب اسوان. هتكلمنا about diabetes mellitus endocrinopathy cross 2.
السلام عليكم. في البدايه برحب بالحضور الكريم، برحب باساتذتي الافاضل دكتوره لبنى حمد الله على السلامه، دكتوره ولاء، دكتور عمرو عمر، كل اساتذتي الافاضل برحب بيهم. طبعا بشكر الدكتور مصطفى على مشاركتي معاه في الايفنت ده. يمكن ده يعتبر كولابريشن ما بين وزاره الصحه والجامعات المصريه، منها جامعه اسوان وجامعه اسيوط العريقه اللي بنتمي اليها. هحاول ما اطولش على حضراتكم. النهارده عندي question is really a crosstalk between diabetes and endocrinopathy. Actually we have two cases. Ahmed and Nadia will answer this question. The first case, Ahmed, 55 years old male patient, came to your clinic complaining of easy fatigability and decrease in concentration. He was diagnosed as a pre-diabetic and was in treatment in metformin PID. Unfortunately, his brother was diagnosed to have a toxic multinodular goiter and have a thyroidectomy. And he came to your clinic frustrated and worried and asked you about the possibility of thyroid disease and is related to his pre-diabetic stage or not. By examination, we found that vital sign is normal, PMI overweight, head and neck showing that patient had a palpable thyroid swelling, chest and heart clinically free, neurological examination actually is clinically free. Lab showing that TSH is 8, normal T3 and T4, and we ordered for a TBO that was positive, and the thyroid ultrasound showing a picture suggesting of thyroiditis, A1C is 7.2, and the lipid profile showing dyslipidemia with marked increase in LDL cholesterol and TG. So Ahmed now is a diabetic and also dyslipidemic and had a subclinical hypothyroid that may need treatments. There are three questions. The first is, there is a crosstalk between the diabetes and the thyroid disease. How does the diabetes affect thyroid disorders? And how does the thyroid disorders affecting the glycemic control in a diabetic patient? The first question, how does the diabetes affect thyroid? Actually, in a diabetic patient, even in euthyroid patient, that it altered the response of the TSH to TRH. And also because of the hyperglycemia and hyperinsulinemia may increase the proliferation of the thyroid tissue and result in a formation of nodule and nodular diseases in these patients. What about the implication of thyroid disorders على glycemic control? Actually, we have a many review article regarding that is relation between the thyroid disorders and diabetes. Actually, it is a two-direction relation. Had a two pillar. The first one is the thyroid disorders prevalent with the diabetes. Actually, the prevalence of type 1 diabetes with the thyroid disorders is a common, as both of them, pathophysiology is an autoimmune disease, with a risk factor more common with old age, the presence of the positive TBO antibody, and the presence of the thyroid swelling. What about the prevalence of thyroid disorders with the type 2 diabetes? Actually, in hypothyroids, overt hypothyroidism is ranging between 6 to 20 and subclinical hypothyroid 10% in a type 2 diabetes with the risk factor advanced age, female sex, presence of the positive TBO antibody and obesity. While the hyperthyroidism, their instance of toxic multinodular goiter or a nodular disease actually more common than the instance of a grave disease in a patient that had type 2 diabetes with more risk in a female patient and advanced age. What about thyroid dysfunction that causing diabetes? Actually, the hypothyroid considered to be a state of insulin resistance, while hyperthyroidism, there more tendency to have a glucose intolerance because of increasing gut absorption of the glucose, increasing hepatic glucose production, and also the direct effect of T3 على البيتا cell apoptosis, وده بيسبب increasing and بيزود الhyperglycemia in these type of the patient that having a hyperthyroidism. The interesting study that published in June in 2023 that enrolled the studies published from 1980 till 2022 will أثبت لنا a relation and the impact of the hypothyroidism on a diabetic patient and even in its complications. So the tricky question here, should we screen a thyroid disorders in a diabetic patient? Actually, ADA guidelines وضحت لنا قالت لنا in once you diagnose type 1 diabetes, you should have a thyroid examination, thyroid function, and ask for a thyroid TPO antibodies. If the TPO antibody is positive with a normal thyroid function, you should screen the abnormality in the thyroid function every 6 months. If it's negative, so it will be annually. While in type 2 diabetes, you should have a baseline thyroid examination, thyroid function and TPO antibody. Once the patient have any sign of insulin resistance, women with PCO, or the patient had a history or actually on a treatment of dyslipidemia. How to manage a diabetic patient that having a thyroid problem? We can use any of the anti-diabetic medication freely in a hypo and hyperthyroid with the following. Avoid using of TZDs in a hyperthyroid patient because it increase and aggravate Graves' opatopathy. Avoid use of the GLP-1 receptor in the patient that having a history of family history of Min syndrome or a history of medullary thyroid cancer. What about the effect of management of thyroid disorders على glycemic control? Actually, after you initiate in a hyperthyroid patient levothyroxine, it will increase the basal metabolic rate, interfering with the action of the anti-diabetic drug, so you just need adjust a dose. While in a methimazole or a carbimazole, there is increasing in the instance of the autoimmune hypoglycemia, so you need to adjust the dose after initiation of the methimazole. Actually, case number 2 is the challenging. عندنا نادية female patient, 34 years old female patient, came to your clinic complaining of polyuria, polydipsia, and history of recurrent fracture with history of osteoporosis. She has history of a UTI recurrent over the last 3 months. She had a positive family history of a diabetes, and she is now diagnosed to have a hypertension. And actually, she was worried and frustrated because she gaining in weight over the last 3 months, about 10 kilo, and her face become there is a facial fullness in her face, and she asked you about if she had the possibility to have a diabetic or not. Actually, المشكلة عندها أكبر يمكن من الدايابيتس. إحنا سألناها هل في أي manifestation of increasing her intracranial tension, either headache or vomiting or blurring of vision. She denied, and asked her about any intake of a steroid. She denied, but the patient actually on CUCs and Tegretol, carbimazepine, and anti-epileptic because she has a trigeminal neuralgia from 5 months. By examination, blood pressure is quite controlled. PMI is obese, face cushionic in appearance, and abdomen showing a truncal obesity with a striae rubra more than 3 centimeter, neurological examination showing actually a proximal myopathy. By the clinical lab, we found that there is a neutrophilia with no shaft to the left, and electrolyte is normal, calcium actually decreased, vitamin D is insufficient, DEXA scan showing osteoporosis, A1C is 7, and thyroid function normal with mild dyslipidemia. Pregnancy test was negative. The question here, what is the cause of the diabetes in that lady? How to manage and how to diagnose that lady? Tricky question here. Should we exclude the Cushing in that lady as one of the endocrinopathy that causing diabetes? Actually, الإندوكراين سوسايتي قالت لنا إن البيشنت اللي عنده unusual feature for the age زي الليدي نادية already هي young age عندها history of fracture وده مش طبيعي, osteoporosis, hypertension. البيشنت اللي عنده progressive feature إلى حد ما predictive ومور للكوشنج زي البيشنت like our patient ده محتاج ان انا اعمل screening of the Cushing. البيشنت طبعا اللي عنده incidentaloma او الchildren short stature with increasing in weight. هذكر حضراتكم ايه اسباب الكوشنج. طبعا اكسوجينس لو العيان بياخد الستيرويد, الاندوجينس either ACTH dependent or ACTH independent, and don't miss ان في حالات معينه بنسميها physiological non-neoplastic hypercortisolism اللي بنسميها سودو كوشنج زي diabetes, uncontrolled, obesity, alcoholism, depression. دول محتاجين نعمل ري اسس, وعشان كده بعتبر الدايجنوزس considered to be challenging. فعندي 3 question علشان اقدر اوصل للدايجنوزس. It is truly Cushing ولا العيان ده ACTH? If it's truly Cushing, it is ACTH dependent. If ACTH dependent, it is ACTH dependent ولا ده ectopic ACTH من another tumor like small cell carcinoma or thymus tumor. الالجوريزم ده بيوضح لنا how to diagnose a Cushing. انا عندي 3 تيست. The first one انت عايز 1 positive test of low dexamethasone suppression test or a 2 positive test of a 24-hour urinary free cortisol must be more than 3 or 4 upper limb of the normal. او عندي 2 test positive test of the late evening salivary cortisol level. If it's positive يبقى العيان ده Cushing, لازم اعمل assess ال ACTH. If ال ACTH is low يبقى العيان ده mainly adrenal ومحتاج انا اعمل reassessment by a CT or MRI MRI abdomen. لو ال ACTH is increased محتاجه افرق ما بين هي ectopic ولا عندي مشكله في البيتيوتري، فبالتالي المفروض اعمل high dexamethasone suppression test and MRI pituitary. If the high dexamethasone suppression concordant with the MRI pituitary يبقى العيان عنده adenoma. If this concordant محتاج another invasive test which is a bilateral pituitary thymus sample. If there is a lateralization يبقى العيان ده عنده Cushing disease. بس خلي بالك في نقطه مهمه جدا عشان احنا اتكلمنا من الاول ده يعتبر challenging problem. في اسباب معينه ممكن تدينا false positive and false negative results. ما تنساش ان اللو ديكساميثازون من الحاجات اللي بتاثر فيها كتير جدا الميديكيشن. البيشنت بتاعتنا كانت ماشيه على كاربيمازبين او التجريتول علشان ترايجيمنال نيورالجيا، وده من ضمن الاسباب اللي ممكن تعملي false positive results، وبالتالي ما اقدرش rely on a low dexamethasone suppression test. Even the 24-hour urinary free cortisol level ممكن يبقى positive even في النون ليوبلاستيك هايبر كورتيزوليزم الحالات السودو كوشنج. وبالتالي الجايد لاينز قالت لنا الجايدلاينز قالت لنا الاندوكراين سوسايتي in a case of a pregnancy اختار 24-hour urinary free cortisol level. In case of a patient that taking anti-epileptic medication اختار in late night او salivary cortisol level. في عيان الرينال مش هحتاج 24-hour urinary free cortisol، لا انا ممكن استخدم low dexamethasone suppression test. وبالتالي نرجع back to our patients. Actually the lab profile showing that cortisol after low dexamethasone suppression test failure of suppression. بعدين عملنا 24-hour لقينا اكتر من 3 لابت of the normal، بس انا محتاج ري اسس لان انا عندي احتمال كبير يبقى false positive. عملنا late evening salivary cortisol وجدناه high، وبالتالي patient is truly Cushing. عملنا assessment of the ACTH actually is high. عملنا high dexamethasone مع MRI لقينا الاثنين concordant، والعيانه actually has unfortunately has a pituitary adenoma، وبالتالي العيانه need to be treated by transsphenoidal surgery. But the question here how to manage a diabetes that caused by Cushing disease او الهايبركورتيزوليزم اللي عندها. الجايدلاينز قالت لنا you can give يعني anti-diabetic medication freely in this patient but with a cautious. ما تستخدمش ال SGLT2 because of increasing the risk of the infection. ما تستخدمش TZDs because of the increasing the risk of the weight reduction and weight increasing the weight and water retention. And finally insulin is good for a pre and intraoperative period. And finally our take-home message. The most common endocrinopathy or diabetes is the thyroid problem. A screening of thyroid disorders once you diagnose type 1 diabetes and after the age of 45 years old, and a type 2 diabetes that having a sign of symptoms or insulin resistance. And Cushing is one of the endocrinopathy that causing the diabetes, and especially in the patient that have unexplained feature of hypokalemic hypertension, or the patient that having diabetes or obesity and osteoporosis. And the last final message, midnight salivary cortisol level and 2-day low dexamethasone is one of the screening tests that can be used in a non-neoplastic hypercortisolism. And thank you.